So IDA is, of course, a global public health advocacy organization dedicated to infectious diseases. So we bring together stakeholders to work on policy and for resources towards infectious diseases. Next slide, please. Our vision is to reduce the burden and improve access to healthcare. So that's in general a vision for us as a global civil society organization, while the mission is to unite civil society organizations working on infectious diseases to improve policies and finance. Next slide. So that was a little bit about our work. So I'm very happy that you all joined us here today. And if you are interested in hearing more about IDA and what we do, we have a lot of information on the website. If you're coming from a civil society organization working in infectious diseases or in primary healthcare or finance, we have some collisions that do exactly this work of bringing civil society organizations around this area. And you can, at all times, become a member, sign up to our newsletter, or become even an active member of our organization and kind of become part of the committees. We have a series of committees that you can also see on our website. So that was a very short introduction from my side. Then over to you again, Carl.
Yes, thank you, Rodrigo. Now our first speaker is Audrey, Senior Business Development Manager at eHealth Africa, where she drives strategic partnerships for public health interventions. An expert in digital inclusion, Audrey will share insights on addressing data gaps and biases in AI models for equitable outbreak controls in Africa, drawing from eHealth Africa's data collection and community engagement strategies. Audrey, the floor is yours.
Thank you very much, everyone. Good afternoon here from Lagos, where I'm based. Thank you very much for the introduction, and I'm pleased to be here to tell you more about the topic which we have gathered here today. And just to drive into that, we at eHealth have decided to go deep into our insights within eHealth Africa, data collections, and of course, community engagement strategy. So I will first would like to tell you just a little bit more about EHA, and then we can then deep dive into my very short, hopefully short presentation. So here we go, and let me know if you can see my screen. Okay, I may not be able to see the call, but definitely.
Yes, good. We can see your slides.
All right, thank you very much. So once again, eHealth Africa is a nonprofit organization, and we are an international organization, but indigenous to Nigeria. What that means is that we are founded in Nigeria and we operate out of Nigeria, but we spread across over 24 African countries where we have done projects. However, we have offices in Nigeria, which is our home country, South Africa, Cameroon, Germany in Berlin, and of course the United States. And we continue to spread our tentacles to ensure that we are able to give more value into improving health outcomes. We have key priority areas for us at eHealth Africa, which is we take into priority healthcare delivery to improve healthcare delivery systems. We also have the public health emergency management pillar. Then we'll have the disease surveillance system, where we help provide, surveillance around vaccine distribution, monitoring, tracking, and we have tools in which we have developed in order to support these different pillars in which we work and provide services to our donors and funders and partners inclusive. And then we have the laboratory and diagnosis pillar as well, where we work around setting up and upgrading laboratory system to meet the expected criteria to be able to serve hard to reach communities, countries, or regions within the African continent, which we are pretty good at. And also within that laboratory system, we also operate what we call the emergency operating system, responding to healthcare emergency situations. And out of Africa, what we do, we set up and hand over to the government or the country. But within Nigeria, wherever we set up in 36 states of Nigeria, we manage those centers as well. And then we have the last part where it's around climate adaptation for climate adaptation in health, food security, and nutrition, where we tie into everything that we do, climate change and interventions and rehabilitations that actually lead to make our systems, our healthcare system, public healthcare facility to be more resistant and adapted to climate change. And one of the heavy things we do around here is particularly always providing solarization projects into public healthcare or primary healthcare centers around Nigeria and out of Nigeria as well. And then I will go straight into some of our services that we provide regarding this topic. At Health Africa, we have what we call the Global Health Informatics. Under the Global Health Informatics, this is the heart and the core of every technology solutions that we imbibe to drive our intervention across Africa. And in doing this, what we provide is infrastructural services, ICT services, field operation and logistics, program management, supply chain and last mile delivery, and of course, monitoring, evaluation, and research. This, we definitely work with our team and diverse of experts to solve challenging public healthcare issues using data and technology. And oftentimes people ask us, what's the E in health? The E in health is really around electronics. So we consider ourselves a huge and sophisticated health tech organization. We have been in existence for almost 16 years at the moment. One of the things we're really good at is having a diverse team of developers, engineers, and all that. And if you look on the right side of your screen, that's some of the product that we have created in a way that we actually may be totally in control of, but no longer in control of. Now, if you look from the center as we go out into the larger circles, from the center are solutions in which have been developed by eHealth Africa, but is still owned by us or sits with us or managed by us. But as you see the circles going wider, those are solutions that we have successfully designed, implemented, and then eventually handed over to either the community, the government, or the country during the transition to make it more sustainable and adaptable in that sense. So each time we create, and some of them are adaptation of one of the many. So you see a couple of names which will be duplicated even within this product. But as we speak, there are always new ways where we try to adapt and create solutions in there. In the era of AI, which I'm going to dive into a little bit, I just want to show you a bit of some of our products, which I'm sure most of us are very peculiar about. The core speaking into some of the topic we're talking here today, it's going to be pretty brief just to get us to think about how we are actually using AI and data in the work that we do. And I would leave you more with questions, and I hope I'll be able to respond, and the rest of the panel as well in that sense, because we're all connected. So Lomis is one of our products. It's a suite technology-based solution that enable healthcare workers and supervisors and other stakeholders in healthcare communities to track stock visibility, order, and make informed decisions. So in this helps with logistic management within the healthcare. This can be used by using USSD web application or even offline capability mobile applications in that sense. And this we use very well around the delivery, stock tracking. So for instance, if we are working with the vaccine distributors, in that sense, this is where some of our solutions come in, where we track how they are moving around, how they are dispensing, tracking the number of vaccine that has been dispensed, how much households are they also covering, hospitals in that sense when they use those things. So this can be used with device offline and offline, and then you can be able to track how this how you achieve most of the movement that you make within the logistics aspect, be able to give detailed reports, aggregated reports, and there's also a dashboard behind the scene in there. I'm going to be rushing through a bit of this, and I'm hoping that perhaps maybe during the question and answer session, I'll be deep diving a bit more. But what this does is send out stock alerts, send out the accounts, Also eliminates waste in that sense, where you're able to take what it is you need to the field in there, and to maintain those temperature of vaccination, or even the cold supply chain situation where that is being used. And what can you really use this for? Like I mentioned, stock level, your mail and app notification on the stock level and expiry threshold, the quantity of products and the waste in store. Then, of course, the functionality, the status of the cold chain equipment, like I just mentioned earlier, and at the health facility at the end of the year. And where we deliver, and when you use Lomis to deliver, it will give you status of the timeline and delivery of the health facility, on-hand stock quantity, actual quantity delivered to each healthcare, and of course the quantity product retrieved from the healthcare facility in case it is overstocked. And then reverse logistics, that's pickup of waste product from the last mile facility, and then KPI on vaccine immunization and details since the last delivery. So all this can be captured on the mobile phone or mobile devices using the Lomis application. And this is just a snapshot of some of the things where we have used them for. So we've deployed in 2014 Lomis stock, which was first piloted across 30 health facilities within the Kano state in Nigeria. And by 2015, it was scaled up to 120 healthcare facilities within 11 local government areas in Kano. Currently, 434 routine immunization healthcare facilities across the 44 local government areas in Kano state use Lomis stock as their inventory management tool. And the application also currently is being used by the Nigerian Center for Disease Control for the COVID intervention management and state facility effective management. So this was very instrumental during the COVID-19 outbreak, where we're able to apply some of all the solutions at the time where we were heavily responding. And of course, other things that Lomis was used is delivery achieved by May 14th, reduction of stock by 3% in Kano. And so these are the successes that we have seen when we implemented Lomis at the time. And of course, over 19 million of dry goods at the end of the day. So this reduces waste, saves time, but also preserves some of the overstock that in most situations may just go, into waste, and of course cost loss. And of course it covered over 900,000 kilometers in Kano, Bauchi and Sokoto state, just to say a few. Now, just to deep dive into the main topic I'm covering in there, which I hope can expand your mind, is why does it really matter? Why does it matter to use technology, AI, data in that sense? We cannot deny the fact that it is important. But like I said, this is just to really keep us to think in itself. So why it matters, I would let you know that AI models are critical tools and for predicting and managing outbreak. Now, if we train our AI tools in that way, in a way it serves us, we can now be able to kind of depend on it and eliminate some of the aspects where human errors may come into play. In Africa, these models are often suffer from data gaps and biases. So when we talk about technology most of the time, we often refer to mostly the developed countries, right? But there's still a level of consumerism that is still practiced within Africa. We need to now step up and cover those gaps. And the other way to do that is to add a little bit of every of what it is that we do in a way to better represent us. So we are not using in a situation where we are having medications or preference of healthcare treatments that are very Caucasian focused, that are not safe for Africans. So we need to work around building our own models to actually address the gaps and the biases. Only what we give in that can give us back, and then we can continue to train model that can help support the intervention and improve our healthcare system and services. Incomplete data leads to misinformation, as we know, prediction, false prediction, delayed responses, unequitable outcomes. Ensuring that equity in outbreak control starts with inclusive and accurate data. So this is why it matters. If we don't have enough data and inclusivity into what it is we need to do, then how are we providing intervention? How are we actually funding? What kind of outcome are we realistically expecting, on the ground? And we can't do that without accurate data, and technology and AI is here to help us. Now, on the next slide, key data gaps and biases in, in Outbreak Outbreak AI. So in applying that, I would speak to, 4 key aspects, which is the geographical bias. Rural and remote region are underrepresented, and we know that for sure. And the reasons are very obvious. There's lack of access, perhaps power, connectivity, even literacy level. That is also a factor. So, and of course, education level. When I mean education, I mean healthcare education, awareness about what to do when they feel in a certain way. And this is high in most rural and remote regions, which we have to find how to meet them where they are. And then the demographic bias, limited data on marginalized group, for instance, women, children, nomadic population. These are marginalized group that we need to continue to cater and continue to improve around. Infrastructural barriers, paper-based products, poor data integration, those are things that we need to consider. And of course, the cultural gaps, health beliefs, local behaviors not reflected in data set. So oftentimes we need to, if we truly want to give an inclusive healthcare services, we want to fund inclusive healthcare products and improve healthcare generally, it's important that we meet people where they are and not just design for the elites or for those who have access to devices, connection, and education in that sense. We have to make it inclusive enough to make the change and impact that we are looking for. Now, Health Africa's strategy to bridge the gap really focus around community-based data collection, where we go into the source. We have our foot on ground, which is one of our biggest strengths across, especially across almost every community in Nigeria, where we bring in mobile tools for them to use, or we use that to be able to collect data and walk around with them, speak the language that they're familiar with, and then, spend time even in that community as well. Work with the community healthcare workers, for hyperlocation, real-time data, and of course, using GIS mapping for underserved region. Those are ways you can use technology and of course, infuse AI into it. Community engagement is really important to ensure that the leaders are heard and be able to speak and influence the local residents to be sure that they have a positive response into the intervention and program or services that you are offering. And then human-centered design of intervention. This is our sector. I don't need to talk much about human-centered design. This should be the basis of everything we do, particularly at healthcare, in healthcare sector. And of course, interoperable digital platform. Integration of national health system. What are the current policies across Africa within your country? How are you ensuring that everything is fitting into each other, where systems are strengthening, system is being improved, system tests some of the ideas that will bring enough for us to see that we need to address certain things, switch certain, or make certain provision adoptable. And then, of course, real-time analytics and feedback loop. These are ways that, technology can actually help if we're focusing on just some of these items in a way that it becomes a cycle in itself where it builds itself. So these are some of our priority and strategy that we include into some of the work that we do. It's not limited to this, but I thought to highlight these key areas that can get us to think. Now, a case study I would like to present is around Ebola outbreak in Nigeria. EHA has deployed SMS data tools in hard-to-reach area. And in this case, we don't just send this SMS, we also build that relationship with them for them to understand the importance of why we are ensuring that their health comes first, or that they need to be healthy to continue to provide for their families, for their children to be able to go to school, and then, contribute meaningfully to the economy in that sense. But having a healthy community, you teach them tools and lessons and knowledges and expertise in a way that can help them live a better and improved life. Community health workers also get trained in collecting and verifying local data that help. With this, we are able to collect those data in itself and then use them in a way that we can bring more interventions that are very applicable, but also help us build tools that is best fit for those community health workers and the residents. Integrating AI tools enable faster contact tracing and, of course, risk mapping. That is very important in there. And then community cooperation increased due to trust and local validation. So in everything that we do, these are some of the things we implemented during the Ebola outbreak in Nigeria, where we're able to add AI tools, ensure that technology was introduced into the work that we do, and then basically just winning, the local residents. And once you do that, you're able to introduce different things so that they understand the expectation and to know that this is actually for their good. Then tackling AI biases through inclusion. I'm going to speak more into the principles of responsible AI in closing, and then that can also get us to think, I believe. So on tackling this, one of the best way we go about it is to empower the community health workers as data ambassadors, and not just speak to them. We get them involved in the process, train them, and build their morale to ensure that they have certain expertise that can transfer, from one job to another, or even any form of intervention or organization who want to bring more healthcare interventions into their community. Then we integrate formal and indigenous knowledge into the AI design. That's some of the things we do. And then validating the AI models through community insight, testing it with them as well to ensure that it actually meets the need or address the need that we have identified that the program or intervention is here to solve. And then from the data gaps to data justice. Data equity is health equity, as a matter of fact, and when we focus on the health sector. And then inclusive AI ensures that no community is left behind. And at eHealth, we build models that reflect the realities of all Africans because it suits every community or country that we go in. If you think of those circles or rings of circles I showed you, those are number of applications that we have designed based on the community, the uniqueness, and also what it is that they need. And some of them may be the same solution, but just tweaked so that it's more adaptable to meet and address the challenges or provide solution to whatever it is that we are expected to do by our donors and ourselves. And lastly, I'll move into the responsible AI. Now, for responsible AI, it's really a 6-principle guide on, how we should be using AI to develop, for development and of course for our use. And in doing that, you can use these 6 to guide in when we begin to include AI or use AI in healthcare, in interventions and emergency, whatever it is we're doing within the public healthcare intervention. Fairness is one. AI tools should treat all people fairly. How might AI system allocate opportunities, resources, and information in ways that are fair to the human who use it? These are questions we need to ask ourselves. Do you see fairness in action? If you see fairness in action, then that's fine. So those are things that we need to consider when we're using AI and data inclusive to continue to improve and have a robust impact or scale the impact that we want. What's the reliability status and safety of it? AI systems should perform reliably and safely. How might the system function? And the question to ask yourself is, how might system function well for people across different use conditions, contexts, including ones that it wasn't originally intended for? So sometimes when we go on to use AI, we have a certain perspective in mind, and sometimes we come from only our perspective, which is not deliberate or cautious. Sometimes it's very uncautious, and that's why you need to ask yourself those questions. Are you using AI or embedding AI into your tool or your project from the perspective of who that is supposed to be serving? And then you have to see reliability and safety in action within yourself and your team. Accountability. People should be accountable for AI systems. Whatever AI it is you use or how you build it, know that it is your responsibility and you should take accountability for the outcomes of it. And the question to ask is, how can we create oversight so that humans can be accountable and in control? And this comes around with your governance, the policies. How do you set them up to serve the communities while you do intervention with AI and data? And of course, transparency, which is very important. AI systems should be understandable. And the question to ask is, how can we ensure that people correctly understand the capabilities of a system? And this is so from the building to your policy, to deployment, to usage, to reporting, to the analysis, those things need to be transparent in itself, because AI is not stagnant. It's always evolved, and it's based on how we use and information we continue to build with. And of course, privacy and security, that has to be considered. In technology, this is a big issue, but with AI, we have to be very much aware than ever before. How do we ensure privacy and security is there? And the question to ask yourself is, how might a system be designed to support privacy and security even while we're saving lives or improving healthcare systems? And then inclusiveness. AI systems should empower everyone and engage all people, regardless of their background. And the question to ask yourself is, how might a system be designed to be inclusive for people of all abilities? See inclusiveness in every action that you take when you're using AI, building AI or data. And that will be all from me. I hope I've not gone beyond my 10 minutes. I know that was a lot of information to take through, and I would stop here, and I hope I'm still within time.
Yes, thank you, Audrey. I think it took around 25 minutes. So, but yeah, thank you for those practical insights from eHealth Africa's impactful work. It was really inspiring. And let me share my screen again. So our next speaker, we have Dr. Nahid Badlia, founding director of Boston University's Center on Emerging Infectious Diseases and co-founder of the Biothreats Emergence Analysis and Communication Network, or BEACON, a global leader in infectious disease preparedness. Nahid will share insights on BEACON's role in advancing biothreats analysis and communication. Nahid, the floor is yours.
Thanks so much. Let me see if I can share my, okay. How do I share in Google?
There is a button named share screen.
And so, okay, 1 second. Share screen, and I am looking for my PowerPoint. There we go. Share entire screen. Do you see my PowerPoint?
Not your PowerPoint completely, but yeah. Yes, now it's in a presentation.
Great. Thank you again for that presentation. And I was inspired by Ms. Ogadu's presentation, particularly around data equity and the importance of that in a global community. I'm very excited to share an open source program that we've developed at Boston University in collaboration with our partners at HealthMap at Boston Children's Harvard Medical School, as well as the Hariri Institute for Computing. So what I want to talk about is BEACON, Biothreats Emergence Analysis and Communications Network. It is a near real-time event-based surveillance that's informal reporting, by which I mean we're not a government agency. We are a academic as well as an international group that has subject matter experts that are based currently on 4 continents, and we're rapidly expanding that. And one of the reasons I wanted to present today is also because we're looking for outbreak analysts that are based around the world to add to our existing cadre. So what we do is we present event-based public health significant outbreaks, clusters, infectious diseases cases. So it's not every endemic disease, but when we see changes in endemic pathogens, or when we see outbreaks specifically that impact both public health response as well as clinical response. Our focus has been One Health, so it's both animal and human diseases. And I'll talk a little bit about our AI and LLM powered technology, which is then always has a human in the loop. There's a QRS here for those who may want to check out the website as I'm presenting as well. And our technical partners are shared here, including the WHO's Hub for Pandemic and Epidemiological Intelligence. So what we tackle with is this problem in the middle. Incredible work is being done by healthcare workers, by public health agencies to do detection with diagnostics and through surveillance on the ground, and then incredible work is being done on response. Our position is in the middle, is to link the reporting when an outbreak has been identified, when a case cluster has been identified, either by an individual public health worker or organizations or international bodies, and to share that on a global level in a politically transparent way, focusing beyond just human health. What we found when we did a landscape analysis is that many of the other partners who are doing this are behind a paywall. As we know, there are other resources such as ProMed who have done an incredible job of this that have also gone behind a paywall. Our ability to use LLM and AI has allowed us to reduce the human workload, which has allowed us to be more facile and more rapid, and allowed us to focus the focus of our outbreak analysts and subject matter experts on really providing the context for why it matters. On our website, you'll see that we share currently our information and an outbreak information, mostly in English, but our plan is to make that available now across all UN languages in Portuguese by the end of fall as well. So what do we actually do? We get signals from many different sources. We get them from HealthMap, which is our partner that does web scraping from all the different places that you see listed here. We have public health partnerships and research academic partnerships around the world that send us individual reports. For example, we had a geosentinel surveillance reports on the Indian Ocean chikungunya outbreak that's going on. In many cases, that was actually unpublished data that was de-identified in returning travelers coming from countries that hadn't yet declared a chikungunya outbreak. Similarly, we have verified reports from individual physicians or public health workers where it may be known in that area, but it may not be known to the global community. So we take all those signals. We have something called a pandemic LLM, which is trained to go through those signals, translate depending on whichever language is coming through, create and copy edit a report, include, and I talk about where this LLM was trained to include incredible amount of reference data as well as historical data, and provide prioritization, really look at the severity of a potential signal that's coming in. At Beacon, there's always a human in the loop. And we do this because part of the way we verify, every signal is verified through either multiple sources or through in-region verification from either authorities or other experts who may be able to verify a potential report. We then make those available in open source reports to everybody. Our future goal is to now turn this database, this LLM, into beyond just predict signal prioritization, using mathematical modeling as well as statistical modeling, machine learning methodologies to do predictive intelligence when a new signal appears to predict the scope, spread, and severity. So what does our LLM do? It focuses on having all these signals that come in. It filters out non-disease related signals. For now, we're focusing on infectious diseases. However, our goal is, the reason we called ourselves biothreats emergence and not infectious diseases emergence, is that eventually we want to move to all hazard, post-viral diseases, cancer clusters. But for now, our work in the LLM is trained around infectious diseases. It extracts key information, looks at relevancy, quality, urgency, source evaluation from where a source is coming from, does severity evaluation, which we aren't sharing because, as you can imagine, that has implications. And we're taking our LLM on real world drive for the next 6 months before we start sharing those scores. It generates a report, and when that's edited and updated and verified and contextualized by subject matter experts, it translates it. The way the LLM has been trained is through domain knowledge, and I'll talk about that in a second, as well as task-specific instruction tuning, which means it has gone through specialized iterative training, looking at historical outbreaks, as well as interaction with the subject matter experts that are on our staff. So here's the body of knowledge from which the LLM is trained. Just to give you a sense, the amount of tokens, this 5.7 billion tokens, is it's so large that we were lucky enough to get a pretty generous grant from NSF, and it almost took almost $1 million to do this kind of training. Our philosophy is that all of this information, all of the reports, as well as eventually the link to all this training material, not the full text because of copyright issues, but the training material is going to be open source and available to everybody, because that is the public good that we're trying to achieve. The second phase is the task-specific instruction, and you can see some examples of outbreaks that the LLM has been trained on to do some of the severity evaluation and non-severity evaluation that I mentioned before. And what we do is something called retrieval augmented generation, where it pulls specific data, not just from prior outbreaks, but also pathogen-specific data from known literature that I mentioned in the past, on the past slide. We do characterization of the pathogen, but also the way the LLM looks at severities. It looks at not just the biological factors, but also geographic and demographic, as well as health systems capacity and the prior experience of a region in handling a particular disease. I always find is impressive because I'm actually serving, not only am I the director of the program, I'm also an outbreak analyst. And so I do reports, and I'm continually impressed by the historical data the LLM pulls in. And of course, the reason we have a human in the loop is for that verification to make sure there's no hallucinations that were mentioned before with AI. I'll skip this for the sake of time. This is just to show you that we use the BERT score to compare our LLM to what's commercially available. The MetaLlama is what we started with as the base model that's commercially available. And that's our LLM at the very top are the two that we're using. You can see how much better the BERT score is, which looks at similarities, and improvements over the non-severity elements of the ranking, how much better it does compared to what's commercially available. I also want to talk a little bit about one of the most important parts of our project, which is a globally based subject matter expert network, which brings in all these different domains of expertise that you can see. And we've spent a lot of time on those editorial policies, what to report, when to report it. For us, it's important not just to be the first to report something, but really to talk about why something matters. There's a lot of dis and misinformation out there for infectious diseases, and we want to add to the good information. And our success is already evident. We launched at the end of April, so really May 1st, and now a month and a half later, we've already reported 212 outbreaks or disease events and about 357 individual reports. And you can see that's across 89 diseases, 82 countries, and we have users from 116 countries, which is unprecedented, partly because we're free and we're available and we're near real time. We've also been in discussions with the WHO Pandemic Hub or inclusion of beacon reports, at least the contextualized reports that are coming in the EIOS system, the epidemiological intelligence from open sources. We've launched a weekly event digest, which you can sign up for using that QRS. And we've onboarded multiple trusted partners who are submitting information to us in terms of potential new signals, in addition to the individually submitted reports that we're getting, almost weekly. So here's where we cover our diseases, and we're hoping to expand this. Again, this has only been about a month, and we're hoping with expansion of our subject matter experts, as well as the partnership, that this will increase some of the coverage that we have in terms of reports. These are our users all over the world. And then I'll skip that. Well, I will mention that what we offer is for public health organizations to partner with us, where they can author the reports, as GeoSentinel, for example, has done for the chikungunya. And so if there are public health partners in the audience today who'd like to be trusted partners, take a look at our website. Please email us. We're happy to work with you to do that. Our long-term goal is to work towards not just this platform, which is open source and context driven, but also we have an international governance board that I'll share in a second about what the composition is. We want to attach this to a global training program. Our vision is that, Beacon may have started in Boston, but it has hubs all over the world. And we're looking for partners in the future to potentially host those hubs in other places in the world. So here are our funders and also our global advisory board, which includes Sir Jeremy Farrar, who's from the WHO, as well as representation from Gates Foundation, from CDC, and elsewhere. And you can see, aside from myself, the director role, there are 3 co-directors on different parts of the project. And I will end with this for others who want to potentially sign up for our weekly digest or just get more information about the website. Or if you know somebody who wants to be an outbreak analyst, we still have left those applications open. We've gotten a really great response, but we'll love to hear from you. And that is it. Thank you.
Yes. Thank you, Dr. Bhatia, for that powerful overview of Beacon's work in tackling biothreats. It was a critical discussion for us all. And now our third speaker is Dr. Catherine Biolik, an infectious disease physician and clinical instructor at Harvard Medical School. Catherine will discuss cutting-edge tools for outbreak detection and address challenges like data interoperability and international collaboration. Catherine, over to you.
Hi. My name is Catherine B. It's really I'm really happy to be here. Thank you for having me. It's great to follow such excellent presentations of specific tools. My goal today is to present a very high level overview. So the last two presentations were fantastic, and I'm not going to be diving into any one specific tool. What I'd like to do is just give a very quick 20,000 foot view of what some of the tools out there for outbreak detection are. My research is in utilizing big data and artificial intelligence to improve outcomes for people with HIV is my specific area of interest. I have a master's in data science that allows me to do more hands-on coding, and I wanted to give a bit of context for where some of this has come. We've come a long way since traditional surveillance and reactive containment, as I don't have to convince any of you, I think. But just looking back at the original SARS, non-COVID SARS with a lower R naught, this was back when we had manual contact tracing with paper, fax machines, Microsoft Excel. There was symptomatic surveillance, which allowed for a fair amount of lag time. And it was a localized response rather than a higher level real-time continual response. And these approaches were shattered when the COVID-19 pandemic came through. Our paradigm was forced to shift. It was a much higher R naught. The different strains had even higher. And then there was pre-symptomatic transition up to half of cases. We were forced to change our methods considerably. Some of the challenges that were faced, and we'll address some of these, were institutional inertia, as I'm sure many of us are familiar, inadequate implementation of existing pandemic playbooks, failure to upgrade hardware, and poor domestic data interoperability was one of the key concerns. So covering some domains of cutting edge tools, I think I might be echoing through some of these. I'll cover first event-based surveillance. It's a domain of tools. Sorry, I'm just hearing the echo. But it's a domain of tools that processes vast quantities of unstructured open source information. So as mentioned in the previous talk, the WHO EIOS is an example of this. It utilizes natural language processing with publicly available data, web crawling, social media APIs, and online forums and news articles. And it extracts indirectly signs of disease outbreaks without a need for an exact string match or diagnosis in a chart somewhere. It can draw a dimensional reduction of this unstructured information to identify these flags of outbreaks spreading. The main interoperability challenge has been a lot of cross-language consistency interfacing, especially with accurate label mapping. Some languages might not describe productive cough in the same way if you're looking for a bacterial pneumonia, for instance. And those have been navigated, I think, pretty successfully. Another domain includes harnessing digital exhaust. Digital exhaust is a very broad term to describe personal data that's already out there in the world right now. And so it's indirect and it's already anonymized sometimes. So one of these examples is search engine queries that people can harvest as a digital exhaust, like how long does the flu last might trend, or loss of smell, and you can cluster IP addresses to sort of identify geographically where some of these trends are starting to spike. You can look for subtle behavioral shifts in this way. More challenging from a privacy standpoint would be harnessing wearable devices or retail sales data. You can look at resting heart rate data if people choose to share that information, or daily step counts. If they're not walking as much, they're staying indoors more because they're sick, for instance, it might be an indirect sign of outbreak flaring in a certain region. This has a lot of interoperability challenges. There's complex legal agreements, data use policies between public health and private corporations. One solution to this, as described in the last two talks, are third-party groups, which can interface between those two areas without a profit motive. But a second option could be a federated learning system. And for those not familiar, that's when a model can train on data locally without any of the identifying information leaving that server. And then the model can be trained on another server and another server without people seeing data from other institutions, the model can train and mathematically adjust weights accordingly. Another domain is sequencing of pathogen genomics. And so this on a larger scale is challenging, but through the use of big data tools like Spark and Python, or especially unsupervised machine learning for dimensional reduction, you can get very large scale genomic data down into its most fundamental features and track real-time evolution. Some tools that exist, there's many, but these are two examples, the GSAT data and NextStrain is a good visualization tool. Here's an example of some visualizations for like a reference tree for its clades, showing ongoing evolution and spread. The options are several and many. The challenges for interoperability are I think, very high with this. Most importantly are just the fact that you're dealing with 3 separate high dimensional spaces. You're looking at the genomic data, you're looking at the patient or person characteristics, and you're looking at geographic data. So you're looking at intersections among all of those individual subsets of all of those domains. One solution should be, I think, a very rigorous common data model approach. I don't think that we've come a long way for this from an international standpoint. I think local common data models are gaining traction, especially with electronic health record data and the PCORI system. But when it comes to genomic tracking, I think internationally there's been challenges in getting data to interface in such a way. And then environmental monitoring is, I think, one of the more popular ones, especially when we were going through the COVID pandemic. Testing samples on municipal wastewater air filtration systems is an ideal indirect way of measuring protected patient data that it doesn't identify any patient data. It bypasses any private information by just measuring what a system is indirectly producing. And the U.S. National Wastewater Surveillance System is one way that has emerged to have a very top-down and systemic approach to providing a lot of that information. But I think even in the early days of the pandemic, it was a lot of boots on the ground and hands in the sewage, just trying to get an idea of where the virus was starting to outbreak and evolve in certain ways. Comparisons are difficult, I think, when you're looking across institutions, when you're looking across cities, when you're looking across countries, because different analysis protocols, collection methods, and which result you're reporting. Are you reporting the variant? Are you reporting concentrations? This hasn't been interfaced very seamlessly right now on a higher scale, but on a local scale, it's found quite a bit of success. I think perhaps integrated simulations might be the most promising future, where there are individual domains of pathogen simulation, but integrating these has had a lot of challenges related to computing power. Where I could see things going is we have these separate simulation techniques with computational biology. We have DeepMind's AlphaFold simulating pathogen host protein interactions. We have very high quality genomic databases. We have some open source biological cell or virus modeling software. These are in very early stages and have only modeled a few very simple bacteria. Mycoplasma genitalium, E. coli was most recently done. I don't think any viruses have been done on these platforms yet. But then there's population pandemic simulation tools which can integrate with these things on a very, very high scale. The existing tools include 2 types: compartmental models and agent-based models, and many more. These are some of the more common ones, though, where the compartmental models would divide populations into different stages of diseases, and agent-based models tracking individual people. The integration of all of this is limited by computing power, where if you wanted to scale up a whole cell model simulated with simulated proteins all the way up to a pandemic simulation, we're not quite there. I think that quantum computing might provide a potential solution for this. And some other tools can include very indirectly global mobility and supply chain logistics with graph neural networks, climate and ecological data for vector-borne and climate-sensitive diseases. And then I think the dream is perhaps public health integration with the EHR, which would be real-time analysis, a pipeline of clinical notes, patient portal messages, ancillary contacts, automated imaging processing, discrete results incorporated into a multimodal model. This is probably the dream, I think, where we can incorporate that in a fully interoperable manner. I think the technical infrastructure for this interoperability on a very high level has two key components, which is data exchange standards for fast healthcare interoperability resources. Is a very common and very universally accepted method of defining how healthcare information is structured and exchanged, adopting existing RESTful APIs, which are HTTP based protocols in the web already. And then content standards too. So the second would be to make sure that we're speaking the same language, independent of English, French, Spanish. The SNOMED CT system tries to bypass this by providing numerical hierarchical labeling system to complement the existing ICD system. Internationally, a framework has several barriers, but the goal is to have a trusted partnership, obviously, with agreements governing the sharing of public health data and biological samples, sovereignty over data, fear of economic penalty and lack of benefit sharing between different economic statuses between countries are perhaps the most cited barriers. In May 2025, very recently, last month, the WHO pandemic agreement was just formalized finally, which is an opt-in, legally binding framework which countries can participate and then have rapid access to grouped pathogen data and have guaranteed access to any of the benefits as well. I'm going quite fast through this to save on time, but in conclusion, I think what we can do as clinicians is to champion data quality. We can demand interoperable systems, and we can advocate for collaborative policy, especially on an institutional level. When we're purchasing from vendors, we're looking at new software programs, we can advocate for systems that have FHIR interoperability. We can advocate using our voice for secure and equitable international data sharing for public health. This is a very high level overview. And yeah, I really appreciate the time to go through this. I appreciate it.
Thank you, Dr. Bulik, for highlighting both the promise and the complexities of these innovative tools. Your insights on collaboration are particularly timely. Now let me share my screen again. We have our final speaker. He is Professor Ernest Tondo, an implementation and MERL specialist at the University of Global Health Equity and an associate professor with extensive experience in Global South. Ernest will explore AI-powered outbreak preparedness, response and prediction capabilities along with regional challenges. Ernest, the floor is yours.
Please, can you share my slide? I'll send it to you.
Yes, you send it in a PDF format. If it's okay, I can share the PDF.
Okay, thank you. So thank you very much, everyone, and thank you for being part of this August webinar. And the time is from talking about AI and data-driven decision-making policy. I think it's interesting that we talk about outbreak and pandemics based on what we have seen on COVID, and mainly in the African context, what we have seen with Ebola, what we have seen with dengue, what we have seen with COVID, what we have seen with monkeypox, which is still ongoing. And in the present content, we briefly talk about the current pandemics, previous pandemics that have been most predominantly in the global south, and how can AI be able to mitigate and other emerging technology have to be able to change the paradigm. And How can it be beneficial to the global community? And the importance of big data, we talk about genomic, we talk about community engagement, and we talk about interoperability. What can we do best to ensure that countries around the world are prepared to respond in emergency, timely and effectively? And what are issues related to ethics and implementation challenges? Next slide. So I have said earlier, in the recent past, we have seen that the world is facing by unprecedented outbreak and challenges. This includes the COVID-19 that we have recently faced, the ongoing monkeypox across the world in about 120, more than 20 countries, the West African Ebola and the Nigeria Ebola, as just spoken by my close friends and sister, Dr. Ogu, dengue in Burkina Faso, in Saudi Arabia, in Pakistan, that continue to be a major problem, influenza, other avian flu in Europe, the antimicrobial resistance, which continue also to be a pandemic, the HIV, which continue to persist with new case of infection related to, maybe related also to the cut down, and the MERS-CoV that continue to severe around the world. We still believe that the impact of AI and other technological advancement may help the world to really mitigate other outbreak and pandemic preparedness. And this provides a basis foundation for novel model, just like what Dr. Nadi have just said, the ALM, or advancing the interoperability across nations. These are efforts to be able to improve forecasting, modeling of dangerous pathogen across the world. Next slide. So it is important to acknowledge that advances in AI have helped us to understand that AI can be a powerful tool in prediction and response. How can it predict? Through early detection, through surveillance, through using mapping the genomic data or the omics data to be able to provide all the formidable information that we need. The example of COVID intervention using this tool had been very powerful in contact tracing, in monitoring, in prediction. I don't want to repeat myself because previous speakers have already presented on that. And it is important to us to actually understand that AI may play an important role, as well as deep machine learning, learning language, algorithm. How best can we benefit of this tool and play on the dynamics and the transformative power that it provides based on what Catherine have just said, providing quality data that can help us to uncover and unravel how powerful data can be in terms of predictive intelligence, predictive modeling, real-time monitoring, advancing integration in order to limit the horror that we have just seen during COVID. Next slide. So it is important to also acknowledge that AI can have shown to be used in model surveillance and response. And I said earlier, there is not further need to repeat myself. AI has been shown that it can be very useful in event-based surveillance, in incidence-based surveillance, in integrated surveillance, as we talk nowadays about One Health approach, how it can really be used at individual level, at country level, at regional level, if we understand the need to accumulate data to be able to enhance outbreak model of significance. And this has also shown that this surveillance, either genomic surveillance or any form of surveillance that can help us to move into the arena of new vaccine and new drug development or discovery that can also help us to really fight these diseases. It has been shown that AI can be a powerful tool in prediction, identifying potential variant, as we have seen during COVID-19 and also during influenza. This has been used as a powerful tool to really help us to quickly adapt to the circumstances and better engage the population to participate or to work along with us. Next slide. It is important to understand that all this new technology provide big data. How can we really use the big data to provide insight in the global surveillance or global survey or global information sharing. We have seen that AI can actually put together all this data, big data that can actually be used using supercomputing to be able to really predict, to be able to map, to be able to identify area that can really be of priority, either priority to research or priority to the global community in terms of pandemic preparedness and response. Next slide. Next slide, please. Next slide. So as we move along, it is important to understand that AI and big data learning are powerful tools that can also help really to do the mapping. How, for example, dengue can be mapped during the outbreak in Philippines, using in different spots where outbreak was mapping to be able to know these are the signals that really can be mapped. These are the area of intervention, community-based intervention. Then we can have tailored community-based intervention based on either the vector or the control measure that can be used to tackle the intervention. So this is very practical approach that we can reuse. We are not inventing the wheel, but capitalizing on the existing information to be able to move ahead. Next slide. So it's very important to understand that big data mapping can be challenging because we need supercomputing tool to be able to help us to really understand, for example, the dengue hemorrhagic fever outbreak. If we know how to use the power of expert in the domain to be able to translate signal into what really is meaningful so that decision maker can take evidence-based decision. This information is very reliable if expert can really understand the context, understand the reality of the context to be able to provide significant information that can help in resource allocation and as well as supporting decision making in terms of pandemic preparedness and response. Next slide. So I have seen here the importance of big data. You can use big data to be able to really detect signal. And as we get the signal, for example, the outbreak of dengue in Bangkok, looking at the trend from the data, we will be able to provide where were the signals and how those signals were actually tailoring with the various outbreak in the various spots in Bangkok. And from there, we can actually use that model by training them to be able to use those signals to be able to provide information that are relevant, that are contextual. We are not reinventing the wheel, but capitalizing on the existing information to see how we can leverage on those information to be able to provide timely information that can help in seasonal trend action or timely intervention. Next slide. So, for example, taking the example of the recent outbreak of Macbeth in Rwanda, where I'm based presently, we realized that Rwanda government was able to defeat Macbeth, hemorrhagic disease outbreak. And within a month, your AI and other digital tool was able to provide timely evidence to improve health policy, to take timely decision action, and high quality information was provided on community-based intervention. And within the month, the disease was actually aborted. Next slide. So you will find here that AI was used to defeat Macbeth in Rwanda. The disease that we know to be very contagious, we only had 6 cases, 15 dead, and several that recover. But the information showed us that AI can be used as a powerful tool from the day that actually the disease was acknowledged, to the day that the disease was stopped. We were able to really engage the various community in terms of timely information, reliable information from the various sources, working with partners to be able to really stop this disease. This is the importance of leveraging on this emerging technology, such as AI, and using together with the big data provided by the various analysis to be able to really map timely and be able to take appropriate intervention. Next slide. So next slide. We can go on and see what AI can help us to be able to map and be able to detect the peaks, the signals that can help us to inform decision making, help us to really timely provide the needed information for resource allocation. Next slide. So AI, as I said, was used as a very powerful tool across the world, from South Korea to China, to the US, to UE, to some country in Africa, using the AI algorithm. We use it to trace contact. We use it to analyze the movement of individuals. We use it to define what next in monitoring, what were the tendency in early detection. So all these tools can be leveraged to really put forward what are the powerful impact that AI can play in helping the world in pandemic preparedness and response. This has been labeled and previous, but most importantly, in information disinformation. We have seen the importance of infodemics and what infodemics can provide actually in the real world in terms of when the world is faced by global threat, and what AI can actually help us with big data to be able to streamline and be able to provide timely information or strategy in terms of communication strategy that can use to be able to contain a pandemic or an outbreak. Next slide. So it is important to actually say that AI has a predominant part in play in pandemic or outbreak preparedness and response, especially in early detection by detecting signal. I think I don't have to overemphasize on what Dr. Gina have just said about the usefulness of LLM model to be able to help in detecting signal early and be able to take appropriate action. But also using it as a predictive model or an intelligent model that can be used to inform decision making if it's well optimized. But we need to optimize these resources. We need to leverage it on it to be able to see how AI and big data can actually be optimized to really help in pandemic preparedness and response. Next slide. I think it's also important to say that this requires a lot of training. And I agree with Dina that, and Catherine, that in this area, the global south is still left behind in terms of capacity, infrastructure capacity in terms of AI, regulatory frameworks that is needed to implement these tools, and as well as capacity building in terms of human resource to be able to really interpret, understand how best this information, this big data information can be used in pandemic preparedness and response. This is important because until we have this capacity needed, we can be moved into integration. How do we integrate AI policy into the current policy and the culture and the norms and the regulation needed to be able to promote responsible use of AI? Ethics, as my dear colleague have just said. It is important for us to really engage the various stakeholders to ensure that the promises of AI can be of good and fairness to the global community. How can we mobilize new partnership across the world to really advocate, as my previous speaker have just said, to accelerate the global good that AI and big data can really provide in pandemic preparedness and response. Next slide. So there is need for us to unleash. AI is very effective and could be used as an effective tool. But as previous speakers have said, the global community, countries have to work on how we can really use AI responsively, put in place the normal regulation and ethics that are needed to really provide the enabling environment to maximize on these tools that in the nearest future are going to play an important role in really provide an early engagement, cost-effective tools, decision-making, and help the world to be able to advert future advert. But this requires further research, and I appreciate what everyone has done. And we come to see that AI will continue to be used, coupled with deep machine learning and other new technology, include biosensor, which are very useful tools, including drone, to really revolutionize the world, as well as earth and data supply that are also useful, combine all together in actually provide more accurate, more reliable, and cost-effective new strategy that can be used to really conquer outbreak and pandemic globally. Thank you very much, and over to the speakers. Thank you. So the floor is open for debate and conversation. Thank you.
Thank you, Ernest, for highlighting the transformative role of AI in the global south and the barriers we must overcome to scale these solutions equitably. And thank you to all our speakers for such insightful and thought-provoking presentations. We now have some minutes for questions from our audience. You can participate in two ways. Raise your hand to ask your question using your microphone, or type your question in the chat box. But in the meantime, Audrey, I have a question for you if you are still with us. What challenges does eHealth Africa face in integrating community-driven data into AI models for outbreak response?
Could you take that again? What challenges?
What challenges does eHealth Africa face in integrating community-driven data into AI models for outbreak response?
I think it is because some of the collection are done manually. I think that's one of the challenges that we do get. As much as we pride ourselves with the footprint we have on ground, you have to be really patient when you're collecting this data. So those are some of them as well. But then the policies, if we think of the Nigerian context as well, those are some of the limitations on how data is being used or shared. Those actually pose as a bit of a challenge. In recent times, the policies have been reviewed, and they're constantly being reviewed when we reach those brick wall where we are unable to use data that has been collected for certain purposes. So the guidelines around that continue to evolve within the Nigerian context. What I would say is the time it takes to manually reach those people, make them understand the purpose of it, and then ensure that you're working around the guidelines that exist at that point in time, and others that continue to evolve as we go forward.
Yes, thank you for your insightful response. I can see someone with XP names asked the question. He or she said, think the speaker touched on this briefly, but could she elaborate a bit more on how is Beacon different from ProMed, your ProMed?
Thank you. ProMed and Beacon both exist currently. In some ways, there's similarities because they're both event-based surveillance platforms. The big differences are that we have a internally trained LLM, which we have made available, which we'll make available for a methodology in about 6 months in an open source for everybody, and all of our reports are actually freely available. I think that we're also a younger organization, and so our expansion of coverage is expanding from human and wildlife to plant and toxins over the next 6 months. I think the big difference is that our audiences are different. We focus on getting on board, of course, public health partners, and we want the public health community to be a big part of our audience, but we focus on creating context. If you look at the reports, and I will put the Beacon website again in the chat, if you look at our reports, we spend a lot of time sharing related resources, as well as a lot of context about historic data about a particular event, because we feel that it shouldn't just be public health. It should be clinicians, and we're actually seeing a huge number of travel clinicians use our service and sign up for our weekly digest, as well as community members and policymakers, because that's who decides in this really difficult time of funding that, what is important. So we make our context an important part of our signals, and not just the sharing of those signals. But these are both services that are important, and multiple services are needed in the field for triangulation.
Great, thank you. And I think Zoya asked a question from all the speakers. Let's, for example, go on.
Yeah, thank you very much. Thank you, Ladi, for actually putting up the beacon. And I think there is a lot of difference that beacon can make from ProMed. And I agree with what Nadia have just said. Actually, we need a system that is real-time. We need a system that is contextual. We need a system that engage the various stakeholders. And we have understood that actually, when you provide such evidence without engaging the various stakeholders, especially the public health specialists, the decision makers, the communities, everybody that is vulnerable, we have actually seen that by involving them, I think we can actually benefit and let the decision making in terms of policy reform, regulatory reform, the norms, they are ready because they understand. They can really see what is live and what is happening across the globe. What are the various, based on signals, based on trend model, what are the signal that has been picked across the world, and help every country, the government, to really see this is what we need to prepare for and really get engaged, especially with the global health on WHO pandemic preparedness, and see how best they can really get engaged and put out a system that can make the world more safe. I think that is most important thing, and make share the data equitably so that people can have access and be able to use the data to take the appropriate decision. Over.
Just a heartfelt thank you, Tambo, for recognizing this is exactly our mission. Thank you for seeing it. Thank you for your support.
Thank you.
Yes, thank you. Ernest, do you want to add something else? No? Okay. I can see that Zoya asked, how do you see the role of AI in healthcare economy in the future? Is it useful, or is it taking human beings' place, causing other economic problems for healthcare givers? And I'm only asking this because of the global concerns about using AI. Who wants to answer, Zoya?
I'm happy to comment. I don't know that AI is going to take too much of clinical jobs unless they're willing to take on the liability of clinical jobs as well. I think one of the major issues with integrating AI into healthcare is the human-computer interaction in general. I think radiologists have maybe a concern, or pathologists have some concern too, but ultimately it should come down to supporting these positions and not replacing these positions. And so, and even in the supporting role, there's a lot of nuance in how we use the AI generated recommendations and support. But replacing, I think, is far away unless they also plan on taking on malpractice liability.
Yes, thank you, Ernest.
Yeah, thank you so much, and thank you for the wonderful question. I think it's one of the interesting questions that I have seen in nowadays. It is good to acknowledge that AI cannot replace human being. That should be clearly acknowledged, and that we should add a leverage on the benefit and the economic benefit that AI could have in really supporting the health system, especially in developing countries or the global south. I think most things need to be done in the global south. And we have seen, taking example from maybe those countries like in Singapore, in China, in Korea, in the US, where most of these are advanced with the use of maybe the internet system, this penetration. One of the challenge in Africa is actually in the community-based system, the internet have a low penetration, and the cost of even the data band are still very high. So, but the most important thing that we should retain from now moving forward is that AI should be, and other accessory tool will be a powerful tool to really help African government, the global south, and even the developing country to accelerating quality health accessibility, taking early anticipatory measure, proactiveness in terms of decision making, in terms of policy, in terms of regulation that are needed to provide an equitable service and quality service to the global community and make sure that the global health security is safe enough for everyone. Over.
Yes, thank you, Ernest. Audrey, over to you.
All right, thank you very much. I think the other two speakers have responded well to it, but usually when I get questions like this, my response will be, I take you back. There was a time you had to take a course to type, to learn how to type on a typewriter. And right now, nobody assesses anyone on how you type, if you type with one hand or 4 fingers, right? And that is the concept I always like to share with people when it comes to, what is the role of AI. The thing we need to be thinking about, the question we need to be asking is, how can we contribute to AI for AI to serve us? I think that's the question we need to start asking ourselves, because it's just another tool that in another 5 years or 10 years, we're not going to remember that AI is something that we were once scared of, right? If you think of the era of when, iPhone or Apple said there'll come a time where you hold a computer in your hand as a device. That's what we do today. So that's the journey we're going through with AI. And, after a while, it becomes part of us. What we need to be concerned about, in addition to Temple, is how do we protect it enough to serve us in the right way and not to harm us? How do we use it in the most positive way in our day-to-day, in our lives, at work, at businesses? Those are the things we need to spend time thinking about, really, because it's just another technology to aid, and depends on how we use it. Thank you.
Thank you.
Yeah, I'll just echo what's been said, but I will just say, look, in the use case of Beacon, it's not replacing humans. It's allowing humans to task shift. Whereas they would have spent all this time summarizing this text and looking up all this historical data, now they just have to spend that time adding additional context and verifying the information. That reduces the human burden, exactly as Audrey said. It reduces the human burden so we can focus on other things. So, but I think that we're not there in the future where we can completely abandon the human for many reasons. The AI, the LLMs are still quite early, right? There's, the second is, there are particularly in disease surveillance, there are political elements to consider. You want a human in the loop, because there are implications to reporting diseases on countries, on individuals. The other thing I was going to say is that there is one risk, right, which Audrey put in at the end of her presentation. My biggest worry with AI is that what's going to happen with that technology is what happens with every technology. Some communities have access to it, others don't see the benefits of it for decades. We cannot let that happen, because actually that training needs to be democratic, exactly as Audrey said. We can't, unless we put that knowledge in from our communities, from the global south, from the global north, we will not have representative LLMs. And that is actually resources. Training those LLMs is resources. That in getting that voice in is not going to be, it's not going to happen passively. We need to be mindful and do it actively.
Thank you, Zoya, for your engaging question, and thank you from our speakers. Yes, Ernest, go on.
One thing that I want to draw here in our attention and the attention of the audience is that we rely on the audience, and we rely in many of us that are experts in the domain to really advocate and promote the use of AI in our various community, and let the government, let the various leaders in the various forums understand the importance of AI, that AI is as a tool, as any other tool, that will help, ease, support, and be a companion of human to be able to process. Either you are a decision maker, either you are a manager, either you are an implementer, either you are a businessman, AI, or a health professional, AI is there to provide you a summary recap, help you to really think otherwise. And the only thing that human being will only be at the center is that the intelligence, the behavior part that is really required from human, AI does not have it, or may have it, but not have it comprehensively as a human to be able to really put it into action. And I believe that advocacy, building from the experience from the Beacon on training the new generation of youth from the global north, from the global south, to avoid the issue of underrepresentation is very capital to take AI technology beneficial to mankind or the planetary health. If we are talking of planetary health, we are talking of how AI can be leveraged in its various positive way while addressing the negative side to benefit mankind. Over.
Thank you for the thoughtful responses. I think now we are nearing the end of the webinar. So as we close today's webinar, I want to reflect on the critical insights we've gained from Nahid's work on biothreats communication to Catherine's exploration of detection tools, and also Ernest's focus on AI in the global south, and Audrey's practical application in the digital health. We've seen how AI and big data are reshaping outbreak control. Yet challenges like data interoperability, equitable access, and global collaboration remind us that technology must be paired with strong systems, partnerships, and commitment to equity. To carry this momentum forward, we are launching a call to action, which you can find on our website, that my colleague also shared it in the chat. This call to action urges all the stakeholders, governments, researchers, tech developers, and civil society to take concrete steps for investing in equitable data systems, foster global collaboration, and prioritizing community engagement to build trust and also scaling sustainable innovations. So we invite you to visit our website to read the full call to action, share it with your networks, and together we can build a future where data-driven decision making saves lives and strengthens global health security. And on behalf of IDE, I extend my deepest gratitude to our speakers for their expertise and passion. Thank you also to our audience for joining us. And a recording of this webinar will be available on our website within a few days, along with the event report, and also we uploaded on our YouTube channel. Please share these resources and stay connected with us on our LinkedIn and website for future events and updates. Thank you once again, and I wish you all a productive and healthy day.
Thank you. Thank you, everyone. Thank you.
Bye.